How's it going, guys? We have a difficult question for pathology step 1, possibly internal medicine 2CK. 49-year-old woman, 3-month history, worsening pedal edema, long-standing rheumatoid arthritis, managed with multiple medications. Biopsy is shown. I was purposely vague because you should know that you're looking at a renal biopsy. You should be able to ascertain, especially with the left image here, hematoxylin and eosin stain, that this is glomerulus we're looking at. Molecular pathology responsible for the patient's acute condition is most likely to be seen in a different patient with which of the following. Okay, so the image we're looking at, I said it's a difficult question, but the image we're looking at, this is actually not too difficult. This is apple green birefringence with Congo red stain. This is very buzzy and pass level for amyloidosis, okay? And you can see amyloidosis in a variety of conditions. Now, if we were to say, okay, amyloidosis in the kidney, right? I've talked about my other clips. The last 2 clips I just put out here on the YouTube were on multiple myeloma, and I've inculcated that the highest yield cause of both renal and cardiac amyloidosis and USMLE is multiple myeloma. It's protein depositing where it shouldn't be depositing. That's what amyloidosis is. Patient has rheumatoid arthritis here. Okay, if you're astute, in the last clip I did mention that you can get it in RA as an example. Okay, I've seen that in an NBME question. So the point is we have amyloidosis here acutely. That's the first step in answering this question. And we're asking, okay, well, the molecular pathology associated with amyloidosis, okay, with deposition of amyloid, could be seen in a patient with which of the following, okay, different conditions. So it's a bit difficult. So let's just walk through the answer choice here. Should I say carpal tunnel syndrome? Wrong fucking answer. This could refer to Hashimoto thyroiditis, all right? So you get carpal tunnel syndrome, obviously just idiopathically office workers with computers, but you should know that hypothyroidism, Hashimoto, acromegaly with growth of the tendons, pregnancy, sometimes a bit of edema. You can also get this bilaterally in construction workers who work with jackhammers. That's on an NBME question somewhere. Point is, wrong fucking answer. Choice B, duodenal ulceration, wrong fucking answer. So you should know that greater than 95% of duodenal ulcers are due to H. pylori. If we're talking about more of a mechanistic condition, more idiopathic, something obscure, we could be thinking of gastronoma, right? Zollinger-Ellison. So it's not a bad thought. If you were not sure of what's going on, you say, well, maybe somehow Zollinger-Ellison could relate. I'm not sure. Duodenal ulceration, wrong fucking answer. Choice C, LAD-P2, wrong fucking answer. I've harped on this in my prior questions that LAD-P2 means pulmonary hypertension. It's exceedingly high yield. You know that LAD-P2, loud pulmonic component of S2, sometimes they can just say loud S2. I'd say about 9 out of 10 times if they just say loud S2, they're referring to a loud P2. Okay, so the pulmonic valve is slamming shut when you have high distal pressure. And also tricuspid regurg, as I said, so holosystolic murmur that increases with inspiration, that means pulmonary hypertension / cor pulmonale. Pulmonary hypertension is the highest yield cause of tricuspid regurg in USMLE. Okay, so loud P2, cor pulmonale, any pathology from the lungs, could also be left heart failure backing up to the right heart, causing a loud P2. You might not notice this in vignettes, but now that I've said it, you'll start to pick it out. Point is, wrong fucking answer. Choice D, flank pain, correct answer. So this could refer to nephrolithiasis. Okay, so this is MEN 2. Okay, so we have amyloidosis here, and obviously this is renal. So in a different patient, you could have amyloidosis, let's say in medullary thyroid cancer, holy shit, where you have apple green birefringence, Congo red stain. And well, who gets medullary thyroid cancer? It's those with RET mutations, RET proto-oncogene, and it can be on its own, familial. Okay, I've seen NBME, there's an NBME question where they just give family members with medullary thyroid cancer, that's it, nothing else in the constellation of MEN 2A, 2B, or obviously part of those constellations. So MEN 2A, you have the medullary thyroid cancer, pheochromocytoma, and parathyroid adenoma or diffuse foregland hyperplasia. MEN 2B, pheochromocytoma, medullary thyroid cancer, myophenoid body habitus, mucosal neuromas. So if this is MEN 2A, presumably, then parathyroid adenoma, high diffuse foregland hyperplasia causing hypercalcemia leading to flank pain. Now, I know some of you watching this clip think that's a big stretch. I don't know what to fucking tell you, okay? You gotta stop your crying. Some of the questions I make are gonna be a little bit more difficult. Let's just hop to the final answer choice here. Choice C, protosis, wrong fucking answer. So it's gonna be Graves' disease, okay? Protrusion of the eyes, exophthalmos. Graves' disease not associated with amyloidosis. Wrong fucking answer. You know the deal. I'm going to make more content. If you like my stuff, subscribe my channel. Appreciate your time. That's it.